Let's see. How do I share screen?
There's a little green button at the bottom that says share screen.
Oh, there it is. Sweet. Okay. Great. Perfect. Okay. So, everyone see my screen? Great.
Yep.
So it's an M&M. Says its title is "Never Get Tired of Exploring." Okay? And I'm Benjamin Lee. Dr. Missoula reviewed this slide, and Dr. Nestor, Sahu, and Benevento all participated in the care of this patient. Target audience, anyone who needs CME, accreditation, Louisiana State University, we're accredited. The disclosures, no one has any disclosures. And there's an evaluation at the end with a QR code. All right, so basically, it's our patient. So he presented to an outside hospital. What happened was that he was doing some remodeling with his friend, and then, mid-swing, a hammer slipped out of his friend's grip and hit him in the left eye and caused a laceration and some bruising. This picture is basically maybe probably 7 days after the initial trauma. So, at the outside hospital, the first thing the ED got was this CT orbit without contrast. And, I bolded the most striking parts to me that, he had a communicated fracture of the roof, floor, and medial wall. And then they commented that there was no definitive open globe injury to that left eye. And day one, when he presented,
I had a laugh, and every time she stopped, oh my gosh, nuts.
Somebody needs to mute their mic.
I don't have anything ever that I have to.
Let's see. Is it James?
Well,
Keep going.
yeah. So at the so basically on the exam they said in the left eye. This is just the left eye. Well, this entire presentation I don't want to talk about the left eye. Right eye is fine. All right. Left eye, presenting visual acuity 2800, pupils were irregular, and then no APD by reverse, supposedly. Goniooscopy, cyclodialysis, cleft 360 with blood throughout. The conj was hemorrhagic and chemotic. Anterior chamber is very deep, 2 times normal AC depth. And then there was some fibrinoid reaction versus vitreous prolapse into AC, and there's some hypema. And iris, complete posterior displacement of the iris lens diaphragm, peripheral iris posterior bowing without visible disinsertion of the iris root, a traumatic cataract with phacokinesis. And then peripherally, they were able to get a view apparently shallow choroidal effusion inferior nasally, and they noted no holes or breaks visualized. And then they said there's blood at the posterior margin and folds in effusion on depression. So, and their plan was day one is they noted that it's sidedale negative and no visible globe rupture anteriorly. And then given that the, and they commented that ocular architecture was maintained on scleral depression without uveal prolapse through any defect. And they started on some drops and told him to follow up tomorrow, next morning. And the next morning when the patient followed up, he was 20/50, basically at interval improvement. They were really, the outside team was very, since the vision was so great, they were very cautious about pursuing any surgical intervention. The B scan, basically it looked basically fairly, or it wasn't very concerning to them. And, they commented that given the exam, you can't rule out a posterior rupture, but, if it's small, it'll likely heal. And they didn't want to pursue a surgical exploration because, they didn't want to be pressing on anything or causing any uveal extrusion or an iatrogenic retinal detachment. After talking to the patient opted for monitoring. Day 3, patient wakes up, 10 out of 10 pain that left eye, and then he comes back. He went from 20/50 day 2 to hand motion day 3. And then they repeated the B scan, and then they said definitively this is hemorrhagic choroidal effusion with detachments. And then it's likely from and they commented likely from hypotony given the cyclodialysis cleft. And then they deferred drainage sclerotomy until 1 week later to wait for the choroidal hemorrhages to liquefy to make the drainage easier. And then this is just a scan, a vertical axial scan. You see the nerve, it's disorganized, the globe contents. And this is a horizontal axial view. Still organized. Inferiorly, sort of see maybe that's a choroid popping upward. And then this, at the transverse 730, this is a classic picture of a kissing choroidal. And then inside the choroidal cavities, it's not clear. It's a lot of material within that, or hyperreflective material, or hypoechoic material within the choroidal cavities. So day 4, they were evaluated by a retina at the outside team. And then basically it says, with the posterior retraction of the lens iris diaphragm, it's suspicious for negative pressure. And then, basically commented, they highly suspect a posterior scleral wound is present. And the retina specialist was just hoping that it was small, that the scleral rupture will be small and self-sealing. And then they're not sure whether or not it had interval worsening. All they know is that there's a choroidal hemorrhage that they're using to explain the interval decrease in vision. So they plan for surgery 7 to 10 days later for exploration and simultaneous drainage of choroidal hemorrhage. So currently they don't know if there's a scleral rupture or if it's just a interval reduction in intraocular pressure that led to the choroidal hemorrhagic choroidal effusion. Yeah. So day 6, patient comes to Ochsner for a second opinion, and then all the exam is pretty much expected. But then I just wanted to highlight the purple box in the left eye. Even at day 6 is edematous, chemotic, 360 hemorrhagic chemosis, defolds. AC is heme cell flare. Iris is dilated. Lens traumatic cataract, and then the fundus exam, total detachment, very hazy, no optic nerve view of optic nerve head. Right eye is normal. And so, the CT was obtained for this patient, and then basically, I pointed to an arrow that they pointed at. So when you look at the globe, the left lobe, again, the globe, it's disorganized contents. You can sort of see the outline of the choroids, and then you can actually see that this break in the sclera. It's white, then black, then white. If you were to refer to the big red arrow that points to a small white arrow, you'll see that. And then it just got a sagittal section, so you can see still like the dense, hyper dense serpiginous thing. That's more likely choroid. And then just, and then I just explored the coronal sections. When you go more posterior, you notice the displaced roof and forefoot. It's important to like assess all the sections available to you for CT or any imaging. So basically, at Ochsner, basically Dr. Benevento said you should consider exploration repair as it may be beneficial to limit the amount of choroidal heme sitting in the retina, even though it's 5 days after injury. So basically, Dr. Nussdorf and I, we went in day 7 for globe exploration, and basically we found the scleral rupture 7 millimeters in length, running 12 millimeters posteriorly, parallel to limbus, the superior temporal quadrant, with the part of the rupture running in the posterior to the insertion of the lateral rectus. And it was a very interesting case because when we were back there, it was very concerning because it was this black mass, very dark brown mass that wouldn't break up or anything. And then Dr. Nusser was worried that it was just like the sclera was totally open and that was this choroid extruding. But eventually, after trying to push it around a little bit, after like five minutes of irrigation and manipulation, it eventually broke up and was coagulated blood. And then as we were we cleared that, the patient coughed and vitreous came out. That was it's basically transparent white jelly that just popped out, and that got us worried. And of course, we just we went ahead and repaired it, and then it was important to close it because in order to drain to drain any suprachoroidal hemorrhage, you actually need to seal, make sure the eye is a sealed unit.
Ben, sorry, quick question. Sorry to interrupt. So the patient coughed. He was awake. He was.
No, he was like he was under general, but for some reason he coughed. He started coughing.
So was it more like a Valsalva or?
Yeah.
Okay.
It was
right.
weird. Yeah, he just coughed, and then it was probably like some secretion getting down his throat or something. Yeah. Yeah. So basically, day 4, Mazula evaluated the patient, and then he says, "We got to drain this. This is final RD, and we got to take out the lens." Day 13 is suprachoroidal hemorrhage drainage. It was external drainage of the choroidal hemorrhage. And this is a term that Dr. Mazula termed, but he said bidirectional tamponade, using the silicone oil which floats to tamponade the retina superiorly, and PFO, which sinks to tamponade the retina inferiorly, and also to tamponade the choroid to prevent additional effusion or hemorrhage. And then one of the surgical challenges was, first one is that even with the sclerotomies, it was just really difficult because there are a lot of loculated pockets that developed within the choroidal cavities. And there are lots of aggressive lavage that wouldn't break it up. And also another thing was that, the cyclodialysis cleft, there was like a lot of suprachoroidal hemorrhage entering the AC. So the case took a long time because he constantly had blood coming into the anterior chamber. So basically,
then if I here, and some of these drainages, all these drainages I find to be particularly challenging, and there's a lot of good videos out there. I think even CNews Group is going to post one in the next week or so using non-valved, trocars to enter the suprachoroidal space. But a lot of times that's a blind passage. I still kind of do it, creating sclerotomies externally in the areas where the apex is the highest of the choroidals, trying to use external massage. I find that the openings aren't really large enough. I try to flay them open, and I think clots kind of get in those openings. I'm not old enough to stick a retractor in those spaces, but sometimes I'll use it externally to kind of break up the clot. But these larger, smoother domes, sometimes if have good posterior visualization, perhaps entering a trocar or a non-valve trocar is a larger bore area, may allow for more drainage, but the blood was still pretty clot, and probably only got about 30% in the. It was enough to internally, but still not a satisfactory drainage. All right, go ahead.
All right, thanks, Dr. Mazula. Yeah. So basically, post-op day 1. Basically the SLAM exam looks like it did before we going in, and then on the fundus exam, you still have some of the choroidals 360, and then the anterior retinectomy with endolaser, and then patient is still LP.
The retina was pushed up against the lens capsule and against the retina on the opposite side. Pretty adherent for just being 2 weeks or so duration, and tried to separate that internally, but I ended up having to do an anterior retinectomy at the adhesion sites just to kind of gain access, try to tease it away. There wasn't enough space to let the perfluorine kind of do a more passive separation anteriorly. So stuff was pretty sticky, even this was fairly acute. Okay, go ahead.
Yeah, so basically, it's actually not day 14. That was a typo. But basically, retina post-operative week 8.5. Dr. Mazzillo saw him like a week and a half ago or something. His vision's hand motion, still poor prognosis. So his vision in terms of entire clinical course went from 2800 at presentation to 2050 the next day to light perception like the following day. And then, after a long course of, management, hand motion to potentially count fingers. And then, so basically, clinical picture, hammer, and to the patient's eye. One thing, and I just wanted to comment, I've from I guess my limited clinical experience of just taking trauma, I've noticed that like when like you can get hit a lot in your eye, but if it's basically not like a very like semi-sharp item, you really the orbit does a really great job of protecting the eye. I don't know what type of hammer this guy was hit with, but I assume it probably wasn't a blunt one. It was probably one with one of those things to remove the nail, it's like a sharp edge. So he probably had some trauma coming in superiorly, and then cause that roof fracture and cause whatever compressive damage there. And then so basically, posterior ruptures and also suprachoroidal hemorrhages, they're not like rare, but then they're rare to me. The first time I've seen such a case. And then three articles. Basically orbital and exo trauma associated with open globe injuries. It's just basically they just did this paper. They did a literature review. They separated it into two groups. Group 1, absence of orbital and adnexal injury, and then most to result in the open globe. It's like the most common injury is a penetrating injury. Group 2, presence of an orbital adnexal damage, most commonly leads to a rupture type of open globe. So penetrating versus a rupture type. And this makes sense because when you have a lot of if you have like a lot of concussive force of some sort, that's like not necessarily sharp, but rounded or enough to get into the orbital space, you generate concurrent injury of orbital and adnexal structure that results in increased likelihood of a posterior lobe injury. And then another article, they basically talked about, they reviewed literature and then talked about cardinal signs for a posterior globe rupture. And actually our patient had all signs, deepening of the anterior chamber with posterior iris retraction, signaling some kind of a negative relative hypotony compared to the other eye, extensive chemosis, vitreous hemorrhage, poor vision, relative afferent pupillary defect, and hyphema. It was documented as no afferent pupillary defect in this left eye by the initial presentation, but I highly doubt that. And then prognostic factors in posterior open globe injuries, zone 3, anywhere basically behind the muscle insertions. Basically, after retrospective review, the conclusion they reached is the most important prognostic factor in the zone 3 open globe injury, zone 3 meaning posterior open globe injury, is the presenting acuity. So with that said, as a whole, from what I take away from all this is that when it comes to trauma, we have to really just take a step back. Instead of focusing on the little details, we should look at the patient as a whole and really assess how much trauma has the eye actually received. When you go back to this list, you have you basically hit all the points. You have like the anterior chamber, you have the vitreous cavity, and you have even the external surface, right? and you have things along the visual pathway bleeding. And then, so, and then as I was saying, from my experience, like an orbit injury is different. A fist, when someone punches you in the eye, is very different from someone accidentally elbow or purposely elbowing in the eye. A fist is totally blunt, an elbow is blunt and semi-sharp. And the thing is that if you're considered for a ruptured globe rule out, do not slow to press the eye. And then, I guess your Dr. Mislow was telling me that, I guess if you explore 100 patients, or if you decide to explore 100 patients and you have and 100% of them come back as positive with open globe, that means you're not exploring enough. Okay? And if you explore 100 eyes and only one of them come back positive, then you're exploring too much. So basically, you want to hit a good percentage of, or a good fraction of your explorations to yield a positive finding. That way, you know that your level of your threshold to decide to take someone for exploration is sufficiently high, but not too high. So take a step back, look at the presenting acuity, especially if they have a lot of fractures. Take them to explore. No one will ever fault you for taking a patient for exploration. So never get tired of exploring. And these are the 3 references of interest. And that is your evaluation code. And I'm done.
Right, Ben, so did this patient have the hemorrhagic stenosis when he first came in from the transfer, or he didn't?
He, let me see. Well,
Patient Osh.
Well, sorry, Anthony, what was that?
When he came to Oshner on transfer, he had hemorrhagic. It was that day 2 or 3 when he had that second pain where I was filled with blood at that point. Yeah. So when he got, he was.
Sorry, you were breaking up a little bit, or maybe it's my internet connection. He didn't, or he did have it?
He did, yes. He had
Okay.
when he got to us. It was probably day 3 or 4 of the outside team seeing him, where he went to hand motion vision with pain, where he had the event.
Oh, got it. So they transferred to Oshner once he had the hand motion vision and all that.
He came on a second opinion. I think the retina team had evaluated him over there, was planning something, 2 weeks down the road. He was frustrated with the experience and came here and underwent a primary exploration with Dr. Nussdorf, where they found the wound and then sent us to him, and we waited, 10 to 14 days or so for it to liquefy, although the liquefaction was not impressive. It was still loculated and clotted.
Alrighty. Would you, I don't know, I tend to try to evacuate the hemorrhage a little bit sooner if it's kissing choroidals, even though it could not be liquefied. Do you usually always wait for 2 weeks, or do you tend to try and do something before if it's kissing choroidals?
Yeah, I'm with you. I was sure if I'd repaired him like a Friday afternoon. I think we decided just to take him to the next OR day, given the prognosis at that point. But yeah, so I wouldn't wait if the retina to avoid retinal adhesions. And I'm wondering if me waiting the extra 4 days, if that made the retina stickier, if I would have just done it, the next day or the day after on a Saturday or Sunday. But I decided just to put him on to my next day.
Got it. I usually use ports to drain choroidals, and what I do is I just eat the valves with a vitractor before I kind of place them, and then I eat the valves with a vitractor, so they're like, they act like valveless ports. Is usually how I drain this. It used to be a lot easier before, because remember the on-valve ports used to be, they weren't metal. They were more like a plastic little flimsy thing that you could actually trim. So it was less scary to place those ports in, I guess. to drain choroidals. It's a little harder with these metal ones.
Yeah, I'm with you on that. It's sort of a blind pass too. The larger temporal one, I probably could have done it, but everything else was kind of this lumpy, bumpy, kind of choroidal pattern where I felt I could have easily gone through and through. Some of the videos, you go really shallow. Maybe you only go about halfway for the trocar insertion to try to find the space. Fortunately, in his case, once we kind of got the lens out, there's enough of a view. But oftentimes these cases, the view is extremely limited. If there's hemorrhage or vitreous hemorrhage, and I didn't want to put myself in a position where I was going to be creating more trauma. But by the time we went in the case, we got a little bit of vitreous cavity. It was pretty clear that his fate was somewhat sealed. So we try to just kind of separate everything out and put some stuff in the vit cavity to occupy space and see if he can absorb the rest on his own.
All right. Very interesting case. It was so I guess for the residents. So the first few things is usually if you have 360 hemorrhagic chemosis, again, as discussed in morning report, if you can't see well inside the eye, you should explore that eye. Then, again, what I was just mentioning is for retina, usually kissing choroidals is more of an emergency, and you want to try to drain those pretty quickly before the retina sticks, and then you get choroidals and a retinal detachment. These choroidals were definitely hemorrhagic choroidals. As Ben noted on the B scan, you can see that hyperechoic material underneath the choroidals. If it was serous choroidals, you usually see hypoechoic material within the choroidals. So at some point, I think Ben mentioned that they thought the choroidals were due to the low pressure, but that would actually give you usually serous choroidals, not hemorrhagic. And the other very important point is whenever you take patients for open globes, for a globe expiration, you need to make sure that the patients are paralyzed so you don't get the bucking in surgery. But what is the one thing you cannot use? Which is the paralytic you cannot use for open globes? Correct. I'm not sure if anybody else has any comments.
Yeah, it was an exciting case, or it was an interesting clinical course. This patient, I think Dr. Mazzola commented in the last note that, it's poor prognosis. We'll continue to follow. Hopefully we'll achieve count finger vision as time goes on. Patient is now an ophthalmos in that left eye, and he might be following Dr. Sahu just for any orbital fracture repair. Yeah.
I just want to echo what you were saying, Ben, about always hesitate to explore. I mean, literally, what is the worst could happen if you explore and it's not open? Nothing. You've taken down the conj. And so 360 degrees of jelly roll chemosis deserves an exploration at the least. Secondly, this patient was light perception, but Steve Charles would always say there's two situations where no light perception vision doesn't count, and that's suprachoroidal hemorrhage and open globe. I guess this patient had both, and so even if this patient was NLP presenting, he deserves the surgery at least, to try.
All righty, sounds good. Thank you, Ben. Good presentation. Can you stop sharing your screen, Ben, please?
Yep. Okay, all right.
All right. All right, who's presenting next?
I'm going to go to R. Thank you all.
Can y'all hear me?
Yep.
Great. I'm going to be presenting a case that I saw in children's last block. My advisor for this grand rounds is Dr. Ellis. Really interesting case that I saw, and I'm really glad that there's a lot of staff here today because I want to get your input. Chief complaint of the patient was I'm seeing double. Here we have the required information. So this is a patient who's complaining of seeing double, 10-year-old female, history of prematurity, born at 32 weeks, and GERD, who has acute onset of diplopia, binocular diplopia, and horizontal. Patient's extremely drowsy, so a lot of the history isn't coming from her. She does know about a recent bout of food poisoning that the patient had and diarrhea 2 weeks ago. No trauma. Again, binocular horizontal diplopia times 1 day, associated with headache, worse when supine, and associated nausea and vomiting. No blurriness of vision, no flashes, no flutters, no eye pain. Has a little bit of mild to moderate myopia, a little mild astigmatism. Family history is significant for SLE and mom, allergies to shellfish, otherwise normal. On base examination, she has great vision. She's 20/20 OU without correction near. Again, she's really drowsy. She's actually nodding off when I'm trying to do the examination. Doesn't have any proptosis. Checked 5 and 7 cranial nerves, and those were normal. Pupils were normal, no APD. Full to finger counting. Did a motility exam. When you look directly at her, there's maybe a subtle esotropia. I did a alternate prism cover test with correction. She had a 14 prism diopter ET in primary, 25 ET in right gaze, ortho and left gaze. At near, she had 6 prism diopters of an esotropia. She also had reduced saccadic velocity on abduction of the right eye, and some abduction limitation of the right eye. Full rotations were in the left eye. Pressures, stereo, color plates, all full, and you have the autorefraction here. Can I get, let's see, probably people who've actually done a pediatrics rotation. Are there any third years here who can describe the ocular motility deficits and then name what it probably is? I can choose somebody. Chris, you want to take this?
Sure. So patient has an ET that's worse on right gaze, and remove my chat box here near reduce saccadic velocity and abduction of the right eye. So like a lateral this palsy.
Yeah, exactly. So it's incomitant. It's one way to describe it. Incomitant, which means for the first years that the amount of deviation is not the same in different gaze directions. So the deviation is greater in right gaze. The reason for that is the patient can't look as well to the right because they have a 6 palsy in the right eye, but they can look just fine to the left. So their
Josh,
deviation.
what is the cause of an incomitant deviation?
The cause of an incomitant deviation. So it's going, generally speaking, the cause of an incomitant deviation. A cranial nerve defect or
paralysis or restriction, nothing else.
Mm-hmm.
And how do you separate out the two? You did it.
So you can look at the saccadic velocity.
And stop right there. That's it. Okay.
Mm-hmm.
Great presentation so far. I got a compliment.
Thank you. So we've established that there's a right cranial nerve 6. For the first years, this is kind of for you guys. It's the most frequently affected nerve in an isolated ocular motor palsy. It's incomitant, as I described. You have horizontal diplopia. It's worse on ipsilateral gaze. Etiologies, amongst all comers, ischemic is going to be most common. You can also have lesions of the cerebellopontine angle, but then you may have other cranial nerve deficits as well. 5, 7, or 8 are common. You'll need to know this for OCAS, but Gradinio syndrome with inflammation of the petrous bone can cause 6 palsy, meningioma, trauma, increased intracranial pressure. GCA is another thing in patients over 50. In people older than 50, it's usually ischemic microvascular disease. You should expect almost complete resolution by 6 months. If there's no improvement in the palsy by 3 months, you have to image these people. And some people will say just image them anyway. Younger than 50, you do need to image these people. And you have to consider other etiologies other than ischemic. So, think about myasthenia, think about thyroid disease, think about getting an LP, think about leukemia in younger patients as well. In adolescents and young folks, you have to think about demyelinating diseases. So we've done the base exam. Let's go to the dilated exam, and I'll show you guys some pictures of the nerves. So can I get a first year to describe the appearance of these optic nerves? I don't know who's on the call, so just somebody please volunteer.
I can give so the fundus photos of the both optic nerves. It seems like there's some swelling around the outside of the nerves. You kind of lose the definition of the vessels because I assume they're traveling up around the nerve. They look swollen. They're pretty symmetrically swollen.
Can you tell me anything about the vessels?
Vessels. The arteries look a little narrowed.
Sure. What about the veins?
Possibly dilated.
Yeah, dilated and tortuous, right? Because they're having trouble sending blood out from the eye because of the amount of edema that's in the nerve. So yeah, there's a ton of edema. Is this papilledema?
Yes.
How do you know? So it's a trick question, right? So papilledema is nerve edema due to increased intracranial pressure, but right now we don't know if that's the case. So right now, all you can say is that it's optic nerve edema. So then we got a B scan. Do you want to just keep going?
Sure.
Sure.
So the B scan, it looks like there's an indentation at the back where the optic nerve is. The signal is low throughout the vitreous.
So there's optic nerve head
finding.
You can see that the optic nerve is edematous, well, not edematous, but at least raised and elevated. So that's fitting with optic nerve head edema. So anterior segment exam was normal. I called it 3+ chronic appearing disc edema. Again, I didn't know if this was papilledema or not. And then there's venous tortuosity. Peripherally, the retina was normal. And so at this point, to summarize what we've seen, we have a 10-year-old girl, African-American girl. She's got an acute onset right cranial nerve 6 palsy and 3+ optic nerve head edema. She's got a headache. That's one of her big complaints on top of the diplopia. It's worse when she's lying down. Drowsiness, nausea, and vomiting. And also this recent bout of food poisoning 2 weeks ago. She had some diarrhea, but otherwise healthy. So what's your differential diagnosis? And let's start with first years.
Meningitis.
Good.
Anything else?
She's on the young side, but IIH.
Yeah, great. I didn't tell you this. External exam, she's actually, she doesn't have like the IIH habitus, if that's helpful. But
Tumor?
Yeah. Mm-hmm.
I don't know about this food poisoning business, but it seems kind of out there, but maybe botulism.
Would you expect optic nerve edema from?
I'm sorry, not botulism. No, I'm thinking something else. Never mind.
It's okay. It's. I mean, for sure. You can get. I suppose you can get cranial nerve palsies, but to also fit in with optic nerve edema would be unusual.
MS.
Mass.
Did anybody ask what she was eating? What did she get food poisoning from?
I didn't ask. Actually, I don't know. I don't know what she ate. That's a good question. I should have asked that.
Did she take any medications?
No, she doesn't take anything.
You know, cult trauma with it.
Great question, though. I mean, absolutely. For optic nerve head edema, for sure. Okay, that's a great start, guys. So I think a good way to do this is to divide it into kind of manageable chunks. So things that can cause cranial nerve 6 palsy and optic nerve head edema, which is kind of the top bullet point, and then cranial nerve 6 palsy alone, and then optic nerve edema kind of alone. So both, right, IIH, you know, worse headache when supine with a cranial nerve 6 palsy, which can happen from increased intracranial pressure, and optic nerve edema bilaterally, sure. IIH is certainly on the differential. Neoplastic, right? So intracranial mass, you get leukemic infiltration of the nerves. Infectious, somebody mentioned meningitis. You can also get encephalitis, like HSV is kind of notorious. And then can't forget about demyelinating and autoimmune. So MS, ADEM, NMO, SLE, any of these things are on the radar. Cranial nerve 6 palsy, you know, you can get congenital 6, but this is something that happened now, so unlikely. Idiopathic, you know, you don't start your differential with idiopathic. Trauma, there's no history of trauma. Young for microvascular. Optic nerve head edema, you know, the things that we always order, infiltrative sarcoidosis, infectious syphilis, TB, neuroretinitis, also possible. There was no macular star. I didn't show you guys a picture of the macula, but the macula looked fine. Toxic metabolic, so B12 deficiency specifically, lead poisoning, and then, you know, ethanol, methanol, ethylene glycol, ethambutol, none of those things was she taking. Degenerative LHO, and you think of like a 30-year-old male and pseudopapilledema. It's not really edema, it's a mimic, but we got a B scan. It didn't have a large A spike when we decreased the gain or anything. So started a workup, and we started kind of focused on, okay, is this IIH? You know, obviously she needed an MRI. She got a CBC and BMP, obviously on admission, that was normal. MRI and MRV were obtained. It showed mild emphysema and a mild cerebellar tonsillar ectopia, but there was no mass there, and there was no signs of enlargement of the ventricles. Lumbar puncture was obtained. Of course, we asked for opening pressures. Opening pressure is only 26 centimeters of water. I discussed this with Dr. Leon, and he had mentioned that, especially in kids, you can kind of expect an even higher intracranial pressure and it still be normal for them. So 26 is not anything that we're like, okay, this is IIH. CSF, no like pleocytosis or anything like that. Protein, glucose are fine. No white blood cells. And then got a culture and smear of the CSF, and that was normal as well. So, I mean, still, you know, with the 6 and the nerves, just consider, okay, maybe this is normal pressure IIH. So we attempted a trial of Diamox, but there was no improvement in the eye movements, no improvement in the headache, no improvement in the disc edema. And so at this point, we can kind of go back to our differentials, start crossing some things out. So very unlikely to be IIH. She didn't improve with the Diamox challenge. Didn't find a mass. This is not just an isolated cranial 6. And we can eliminate some of the things down at the bottom for optic nerve head edema. So at this point, we want to get kind of the other things for optic nerve head edema. So ACE and lysozyme and chest x-ray for sarcoid, all of those are within normal limits. Her syphilis studies were negative. TB quant gold was negative. Even got a Bartonella, IgM, IgG, that was negative. ANA was negative. That's extremely sensitive for SLE. That was negative. Lead was normal and B12 was normal as well. And so we kind of cross out those things. It leads us kind of to the infectious. Okay, is this like a viral, bacterial, fungal meningitis? Unlikely based on the culture and smear, or, you know, a different type of infectious encephalitis. So additional workup was obtained on that front. And then as far as demyelinating and autoimmune, that's still on the radar. So large workup is done. She gets ANA and ENA panel that was normal. ESR, CRP were normal. Thyroid studies were normal. She was given an EEG. It showed mild, diffuse, bihemispheric cerebral dysfunction. Pneumonia, you know, you can get hyperammonemia can cause mental status. So that was attained as normal. COVID, IgG came back positive. PCR was negative ×2. She did develop a dry cough during the admission, but it was negative as far as the PCR. CSF studies, a meningitis panel, an autoimmune panel, oligoclonal bands, flow, all that came back normal as well. She did have some elevated complement in IgG and IgA. And then to rule out some more infectious kind of meningitis versus encephalitis, cryptococcal antigen, CMV urine, PCR, EBV, and toxo IgG all came back, and those were all negative. So at this point, the patient's actually getting worse. Progressively becomes more drowsy, more somnolent, and then she becomes just frankly encephalopathic, extremely agitated, screaming. And then she has a witnessed possible seizure. This was 5 days after I had seen her, and she was transferred to PICU. And at this point, a repeat MRI brain was obtained. I remember the first MRI was essentially, for our purposes, normal. And this is the new MRI. Can I get a first year to describe?
John?
Sure. So these are axial cuts of an MRI. Looks like with the left-hand image starting at the their T1, I think this is a T1 cut. They're well circumscribed, hyper-intense lesions near the inferior horn of the lateral. And going to the middle image, there are also some T1 hyper-intense lesions in the gray matter, and then I can't see the other one, and it extends into the right image as well.
Right. So this is actually a T2 flare. I like that you said T1 though, because you're probably looking at the ventricles and seeing that it was dark, but it's T2 flare. And it's showing these numerous lesions throughout actually it's the white matter. So the gray matter is kind of along the, the edges of the sulci and gyri, and then kind of more internally, that's where the white matter is, okay? So white matter lesions kind of all over the place, so. It's concerning for demyelination versus, an autoimmune demyelination versus even potentially embolic, right? So a hypercoagulability workup is obtained. She gets a TTE with bubble study. She gets a PT, PTT, lower extremity Doppler, antiphospholipids, fibrinogen. Those all come back normal. So she had that CSF autoimmune panel and oligoclonal bands, again, just as a reminder, that was negative. So the presumed diagnosis was autoimmune encephalitis. She was pan-scanned. A lot of times, the underlying etiology of autoimmune encephalitis is a not yet diagnosed tumor that's causing a perineoplastic effect. And so antibodies are tested for as well as doing a pan scan looking for tumor. So autoantibodies were tested for MOG for ADEM, aquaporin 4 for NMO, GAD65, NMDA receptors. These are all kind of common things. These all come back negative. She was started on Solumedrol, 500 milligrams BID times 5 days. She was also given plasmapheresis times 3 days, and then 2 more days every other day. She's also started on Keppra for seizure prophylaxis and GI prophylaxis for all the steroids with famotidine.
And Josh, there was some patients who, COVID patients, even after they recovered from the respiratory issues, who developed, demyelinating leukoencephalopathy. But I don't think I've ever seen one this young.
Spoiler alert, Dr. Mazzullo. Yeah, no, I'm going to talk about COVID, and for sure, that's a great point. I'm glad you brought it up. So we'll go into the neuro-ophthalmologic effects of COVID in just a second here. So autoimmune encephalitis, basically what you have, the underlying pathophysiology is you have antibodies against either, and it's divided into 2 groups, either neuronal cell surface proteins or synaptic proteins. And the proteins that are well known are listed here. Some of them, obviously, we had tested for the MOG, the NMDA receptor, aquaporin 4, and so forth. But the absence of autoantibodies does not exclude an immune-mediated etiology. A lot of times it is paraneoplastic. Oftentimes it'll be like an ovarian teratoma, so you do need to pan scan these folks. A lot of times you'll have neurological and psychiatric changes, but without fever or CSF pleocytosis. Again, sometimes you will have those things though. Examples are anti-NMDA receptor encephalitis, limbic encephalitis, basal ganglia encephalitis, ADEM, Bickerstaff's. These are things that I think in general neurology is going to be taking the lead on, but it's good for us to at least know a basic summary of what the etiologies are. It's important, if you obtain a brain MRI early, it may be normal. And then if you get a repeat later, then you may see the white matter changes on T2 flare. One thing that you definitely have to rule out is infectious etiologies, especially HSV, that can really definitely mimic autoimmune encephalopathy. And so in the Lancet in 2016, Grouse et al. Came up with a diagnostic criteria for autoimmune encephalitis. And basically they have it divided between possible autoimmune encephalitis, definite autoimmune encephalitis, and autoantibody negative possible autoimmune encephalitis. So ours would be that third panel on the right. Rapid progression, less than 3 months. Working memory deficits. I don't know if they tested working memory. I know they did get a neuropsych consult, so I'll have to see. Psych symptoms for sure, altered mental status, 100%. MRI findings suggestive of encephalitis, yes. Didn't get a brain biopsy, didn't have any of the CSF pleocytosis or oligocolon bands, but did have increased IgG. And then exclusion of other things like ADEM and Bickerstaff's, which was obtained with the autoantibodies that were tested for, and then reasonable exclusion of alternate causes. That's kind of the big point there, is were we really excluding alternative causes? And then if you want to, you can kind of take a look at the other things, the other panels there kind of later. I just want to move on. So the treatment and prognosis for autoimmune encephalitis in general, there aren't any randomized control trials for immunotherapy, but first line, you're going to use corticosteroids is what's typically done, plus IVIG and or plasmapheresis. If there's no improvement with steroid, then consider rituximab or cyclophosphamide. If the steroids did work, however, you can maintain them on mycophenolate, which is Cellcept and azathioprine. Alternative therapy is if your first line or your second line don't work, then you can use tocilizumab or low-dose IL-2. Young patients tend to do better, and you do have to repeat tumor screening because they may be having paraneoplastic effects from a small tumor that are clinically significant before the point at which the tumor is large enough to be diagnosed or seen on imaging. So you do need to kind of repeat screening frequently if you don't see a tumor initially. Repeating antibody testing isn't useful. It's not a good biomarker for disease activity. Some of the antibodies can remain on the testing for years. So it's not useful. So as Dr. Mazzula had mentioned, this patient had COVID-19. COVID-19 was positive. She had diarrhea, which as we know can be a presenting sign in COVID, and had negative autoantibodies for autoimmune encephalitis. So we have, I did a literature search, found a couple of papers. Here is a paper from 2020 where they were asking what are the effects of COVID on the eyes, looking at humans and animal models. It was a review paper. So in cat and mouse models of coronavirus ocular infection, you can get conjunctivitis. We all know about the conjunctivitis. You can also get anterior uveitis, retinitis, and optic neuritis. A strain of COVID coronavirus in 2004 caused conjunctivitis. Tear samples have been found to contain SARS RNA, but it's unclear if that is from direct inoculation onto the eye versus migration through the nasolacrimal duct. And as we know, COVID-19 is associated with conjunctivitis. This is a case reports case series. There were 2 cases anyway. The reason they wanted to look at these was that in a study in Wuhan, 37% of patients, of the 214 patients that were studied, had some sort of neurological symptoms. In case 1, and these are patients who had ophthalmoparesis and who had COVID. This patient had a partial left third and bilateral 6 palsies, as well as left hyporeflexia and hyposthesia and gait ataxia. COVID-19 was positive on PCR, showed T2 hyperintensities of the left cranial nerve 3, was treated with IVIG. They assumed it was a Miller-Fisher variant of Guillain-Barré, and then Plaquenil for COVID back when they were doing that. And the patient had partial improvement in neurologic deficits. Wasn't sure if it was due to treatment versus just time. Second patient had a right cranial nerve 6 palsy, fever, hypoxemia, and normal LP opening pressure. MRI showed an enhancement of the optic nerve sheaths and posterior tenons. COVID-19 was positive on PCR. She was treated with Plaquenil, and gradually over time, the diplopia improved 2 weeks after discharge when they called her up. So the conclusion is that there may be an acute demyelinating inflammatory polyneuropathy that occurs secondary to the virus, either as a result of an immune response, kind of almost like an autoimmune effect after the virus has infected you, versus direct inoculation or direct infection of the virus causing these things. So in conclusion for the case, her mental status, patient's headache, and even her abduction limitations of her 6 nerve palsy did improve several days into treatment with steroids and plasmapheresis. She did have, obviously, persistent disc edema for the first years. That's not going to go away immediately. She's finishing up a steroid taper, and she does have follow-up with neurology and ophthalmology. I wanted to get staff's input on this. I think this may be a case of COVID, however, that had caused the demyelinating disease. And it's something that I think I'm going to try to write up. That's it.
Yeah, Josh, this is Zach. I actually just during your presentation, just Googled around, and there's actually a paper published in an adult, though, with asymmetric demyelinating disease from COVID-19. It's kind of similar to yours. So, so there's one other case.
Josh, great presentation. Not good, great. Maria, give him a gold star, okay? I'm not going to say I have the answer as to what did it, but let's go back to the basics for about 30 seconds because it's getting late. First years need to know. Somebody comes in complaining of diplopia. There's several questions you ask, and then there's an exam. You need to put on your strabismus hat. And Josh did it. Is it horizontal, vertical? Does it go away with eye closure? Is it monocular, binocular? Cross diplopia, uncross diplopia? They're going to tell you what it is before you even look at them, okay? Then you need to do the proper exam. Everybody that comes in with complaining of diplopia, please, nobody present anything at grand rounds without these findings. Don't just say, the eyes don't move right. You got to have muscle balance measurements. Prisms need to be used. Ductions and inversions need to be described, and you need to measure saccades. Concomitant deviation, as I mentioned, are either paralysis or restriction, determined by saccadic velocities or forced ductions. And so therefore, that's what you need to do in real life, and that's how you need to present to the patients. Very good presentation in that regard. And I think you ought to write it up.
All right, will do.
I just have a quick question. I think the best you can just say is an association between that the COVID testing is positive and this patient has these kind of symptoms. I don't even know how you can prove, or how any of these cases can prove that it's not just a concomitant events that happen. Like maybe this patient had Miller-Fisher. On top of that, someone infected them with COVID.
Definitely. I don't know. I don't
The
know.
workup is fairly extensive, and there are cases in adults of that demyelinating leukoencephalopathy. So, I mean, you could try to make a correlation. It's just, I'd have to discuss with an expert, who's good at reading the MRIs and seeing if there's some correlation between the adult cases and the case in this child. But I've not seen a case in a child or even one reported. I mean, maybe it's out there now. I mean, the literature is just pluming every month with these types of things. But even if it's been published, publish it again. It's a great case.
All right.
Yeah.
Sounds good.
Josh, did you guys have a CBC?
Yes. It was. Let me see if I can pull it up real quick.
Said it was normal on admission.
It was normal.
It was normal. If you want exact values, I can get it. It'll take me.
No, I just wanted to see if it was normal or not.
Yeah, because we were thinking about leukemic infiltration, so that's why I really wanted to look at it. Was there something specific that you were looking for?
Yeah, just that, and maybe something that would indicate this was a viral thing.
Like a lymphocytosis?
Yep.
Let's see.
Ricky's saying it is a viral thing.
Yeah.
Yeah, exactly. So I mean, it would show that it's a viral thing.
Yeah. No, I can't pull it up immediately, but it was normal.
It's okay. All right.
Everything's with normal limits, so.
Josh, when she came before did she present to the hospital before when she had the bout of diarrhea? Or did they give her that diagnosis of food poisoning?
No, that was per the family. Like, they didn't bring her in.
I would have been curious if she had had a CBC then.
Yeah, no, that was per the family. She had eaten the wrong thing, they said. I didn't ask what it was.
I would have
after
been
eating.
curious to see if there was leukocytosis back then. Okay.
Yeah.
How old was her sister?
Her sister was older than her. She was probably, if I had to guess, mid-teens. I don't know. I don't know how old kids are. She was probably like 15, 16, something like that.
And she was the one giving you all the history.
Mostly, yeah. And then later mom came and corroborated.
Okay.
Yeah.
Very interesting case, Josh.
Thanks.